Hello everyone, Dr. David Warmflash here with another flash moment in medical science. Today's topic, we're doing patent foramen ovale, PFO. This is a connection between the right atrium and the left atrium. It's left over from the foramen ovale, which is supposed to be there during fetal life. But this is a really interesting anomaly because, first of all, not really clear if we should really call it an anomaly because a lot of people have it. Depending on which report you read, it's going to be anywhere from 25%, even close to 40% of all people. So, is it really an abnormality? Not clear about that. Now, it's different from an atrial septal defect. Let's just go over quickly what that difference is. In an atrial septal defect, you have actually a hole in the septum between the left and the right atria. Now, foramen ovale is also a hole, but the difference is the foramen ovale has a kind of a swinging door thing on it. And it's not the kind of swinging door that you might see in the old movies from the Old West where the bad guy walks in his saloon between the swinging doors and they just swing back and forth and they keep swinging as the bad guy is trying to kill the sheriff and whatever. It's the kind that opens just one way. Because really, what is that swinging door? It's really the edge of the septum primum, which is one of the two sides of the intraatrial septum that grows during embryology. You got the septum primum and the septum secundum, which comes down the other way, and it ends up being kind of a double wall, but it's not a fully double wall because there are holes in there. You got an ostium primum and a septum and an ostium secundum. And one septum covers one of the holes, one ostium and then the other ostium. The septum primum covers the ostium primum, the septum secundum covers the ostium secundum. And if everything's working right, the only opening you have is underneath. I'm actually doing this backwards because the recording is in the reverse. But underneath, you have a little flap that pushes out into the left atrium. And as long as the pressure is higher in the right atrium, which is how things are during fetal life, that flap stays open. But once the baby is born, the lungs fill up with air, the pressure goes down in the pulmonary circulation. Now the pressure is higher in the left atrium, and it's like a little one-way valve. It pushes the foramen ovale shut. So it's different from an ASD, which you always have open. Now, the catch is, though, when there is shunting, it actually goes the opposite direction from an ASD. When the ASD always goes from the high pressure left atrium into the lower pressure right atrium because it's just opened. But with a patent foramen ovale, it's like a one-way valve going in the other direction. The only time you ever get blood flow is from the right atrium into the left atrium. And once you're born, that only happens intermittently, or if there's a problem, causing a higher pressure on the right side of the circulation, such as Eisenmenger syndrome, which is after you have a left to right shunt, you get pulmonary fibrosis, an increase in the pressure inside the pulmonary vasculature, causing very high pressure on the right side of the circulation. And then if there's a PFO, then you can have blood moving the other way from the right atrium into the left atrium. But you can also have movement momentarily for short periods of time if there's anything that raises the pressure inside the right atrium. Could be like a really powerful cough. That can do it, or you can have from straining while going to excrete the bowels, or during labor and delivery when the woman is pushing really hard, and also in environmental situations like scuba diving, certain pressure change situations, certain space flight situations. Yes, having a PFO can make a difference in those situations. And there's all kinds of debates about, should you let someone with a PFO dive? Should you screen people for PFO doing the basic physical for diving? Now, because what happens in a PFO, it's not really open all the time. It's only open because of the pressure, and that doesn't happen in everybody. Normally, in most people, even though the pressure from the left atrium, increasing its pressure, pushes that flap shut, a one-way valve, it later seals shut. It kind of locks. It's like the swinging door that then locks close, usually after a few months of life. And usually by about a half a year of age, usually the foramen ovale is closed. Well, let's go through the fetal circulation a little bit so you can appreciate how this happens. Okay, why do we even have a foramen ovale in the first place? Well, it's because blood that's oxygenated doesn't get oxygenated from the fetal lungs. The fetal lungs aren't doing anything except getting ready to become newborn lungs. Now, the oxygenated blood comes into the fetus from the placenta, which is coming from the mother. How does that even work? How does the oxygen even move? Well, first of all, there is more affinity for oxygen to attach to fetal hemoglobin versus adult hemoglobin. That's because the adult hemoglobin has beta chains, whereas fetal hemoglobin has gamma chains, and I'm talking about toward the end of pregnancy. There's actually an evolution of the different chains going throughout pregnancy. What would ultimately become the alpha chains, there's different kinds of embryonic chains playing that role earlier in development. Now, getting close to birth, you got the two gamma chains and the two alpha chains in the fetal hemoglobin. So oxygen kind of prefers attaching itself to hemoglobin. So in the placenta, oxygen will tend to move from the adult hemoglobin to the fetal hemoglobin, even though the red blood cells of the fetus never come into contact with the maternal red blood cells. It just moves across the membrane. There's maternal blood vessels and there are fetal blood vessels, capillaries, fetal capillaries, maternal capillaries. But there are other things that will drive the gas exchange. There is a beautiful effect called the Bohr effect. In the Bohr effect, when the hemoglobin, whatever type of hemoglobin, but in this case it will be the maternal hemoglobin, encounters a high CO2 environment, that hemoglobin will release oxygen. So the Bohr effect causes you to release oxygen. And then, so the maternal hemoglobin will kind of liberate that oxygen, which already wants to go to the fetal hemoglobin because there's greater binding affinity onto the fetal hemoglobin. Now, the other direction is the Haldane effect, named for the physiologist Haldane, lived in the late 19th century, early 20th century. And the Haldane effect, high oxygen will release CO2. So this is a way to release CO2 from the fetal blood. Now, CO2 is a little different than oxygen in that oxygen is almost completely carried by hemoglobin, but CO2, only some of it is carried by the hemoglobin. A lot of it is simply dissolved in the blood. And you have the CO2 bicarbonate system that holds on to a lot of it, which also helps with the acid-base balance, but a fairly good fraction is bound to hemoglobin. And when that encounters high oxygen concentration, because it's in the placenta where it's getting oxygen from the mother, it's going to help liberate the CO2 by way of the Haldane effect. So what you have now is coming from the placenta into the fetus, you get oxygenated blood. And it's coming in by way of the umbilical vein. This is one of those cases where a vein has the oxygenated blood. And then in the umbilical cord, you also have two umbilical arteries. Guess what? They carry deoxygenated blood. So it's kind of like the reversal that you have, just like in the pulmonary vasculature, where the pulmonary veins are the vessels with the oxygenated blood, and the pulmonary artery is the deoxygenated blood. Now that pulmonary, the umbilical vein blood, which is oxygenated from the mother, that comes into the fetal abdomen, and at that point there's sort of a fork in the road. A lot of the blood will go through the liver, actually. It'll go through the portal vein system, which will take it through the liver. And then from the liver, it'll go into the fetal IVC, the inferior vena cava. But much of it will bypass the portal system, bypass the liver. It'll go into the ductus venosus, which will take it to the IVC. So again, that blood also ends up in the IVC. So it really doesn't matter which side of the fork you take. You're going to end up in the inferior vena cava, which then is going to carry you into the right atrium of the fetus. And at that point, you got a lot of oxygenated blood coming into that right atrium. Now, there's also some deoxygenated blood coming in from the upper body, because it comes in through the SVC, the superior vena cava. But you still, when it mixes, you get a lot of still a pretty high level of oxygenation in that blood. But it's mixed. It's purple. They usually draw it as purple. And if you were to take a pulse oximetry of that blood going through a blood vessel where you could actually measure it, you'd find it is not totally unsaturated like venous blood being in the 70%. It's going to be maybe in the 80s, somewhere like that. And it's a continuum. It's not like it's all of a sudden purple blood, all of a sudden red blood. But it's enough for the fetus, especially given that you got the Bohr effect and the Haldane effect to help with releasing oxygen where it's needed in the tissues, and releasing CO2 from the tissues and getting that into the blood, and some of that onto the fetal red blood cells. And plus, you also have the affinity of that fetal hemoglobin. And even though the fetal hemoglobin tends to hang on to oxygen even more than adult hemoglobin does, because of all these effects, you still have a good concentration gradient taking that oxygen into the fetal tissues. And since the fetal lungs are collapsed or not doing anything, you don't want the blood to go to the lungs. You want to go across the foramen ovale from the right atrium into the left atrium, to the left ventricle, and into the aorta to nourish the fetal tissues with oxygen. And, well, some of it, though, does get into the right ventricle. But most of that blood that's oxygenated in the fetus that gets into the right ventricle, most of it's going to go through the ductus arteriosus, which is a little blood vessel connecting the pulmonary artery with the aorta. Now, what's the consequences of this foramen ovale staying open or having the potential to open, having that flap? It's not the same consequence as having an ASD, where it's going to be a left to right shunt. Not at all. It's the opposite. The consequence for most people, really nothing ever happens. But on these occasions like we're talking about with scuba diving pressure changes, and if there's sudden decompression, if you're in aircraft, situations like this, pushing on vaginal delivery. If someone's known to have a PFO, it's pretty bad, then you might want to think about doing a cesarean section instead, because there is this kind of risk where you could have a paradoxical embolus, which is where there is an embolus generated not in the left atrium, which is what you really worry about in terms of the atria producing an embolus, which could go to an organ such as the brain and cause an embolism. This is a paradoxical one where it actually would start on the other side in the right atrium or come from somewhere else, like from the venous system, but because of a pressure change, be able to get through, pop through from the right atrium into that left atrium and then go anywhere. If it goes into the coronary arteries, it can cause a myocardial infarction because that's a coronary embolism caused by an embolus getting into a coronary vessel. If it goes to the spleen, there could be a splenic infarct. It could go virtually anywhere. It could cause an infarct in the intestine, or if it gets up into the brain, you can have a cerebral embolism. That's a type of a stroke. So those are the consequences, potential consequences with a PFO, patent foramen ovale. And that's enough for the lesson today.